Dear Chairman, dear colleagues, I would like to begin by thanking organizers of the Congress for the acceptance of our representation on all the team we had participated at our study. Okay. So I am going to present you our multicentric study on outcomes of robotic surgery for high-risk endometrial cancer. The endometrial cancer is the second most common gynecological cancer in the world, and the first one in developed countries, particularly in European countries. Two types of endometrial cancer have been described for 30 years. The type 1, or endometrioid carcinoma, and type 2, or non-endometrioid carcinomas. European guidelines have defined three kinds of risk for the endometrial cancer. The high risk is defined as the stage 1B grade 3 endometrioid carcinoma and all the non-endometrioid carcinomas. The surgical procedure recommended for this kind of risk is a total hysterectomy, bilateral salpingo-oophorectomy, and pelvic and para-aortic lymph node dissection. The minimally invasive surgery can be considered, but it's not the reference. The objective of our study is to assess the feasibility and the outcomes of robo-assisted surgery in high-risk endometrial cancer. We have realized a multicentric descriptive retrospective study in 6 centers in France and 1 center in Belgium from January 2010 to January 2017. Inclusion criteria was patient who had high-risk endometrial cancer as defined by ESMO guidelines and who had robo-assisted surgery, all the procedure in the same time. The primary endpoint was the conversion rate, and secondary endpoint were per and post-operative complication. 67 patients were included. The mean age were 66.3 years. The mean BMI was 26.1 kilogram per square meter. Majority of our patients were Caucasian, and 40% had a past history of pelvic surgery. 5 conversions occurred, all by laparotomy. The main reason for the conversion was the presence of adhesions and occurred at the beginning of the surgery for 2 cases, and after the para-aortic lymph node dissection for the 3 other cases. All patients have a total procedure, and no perioperative complications were noted. No patients were transfused during the intervention. Our mean operating time was 288 minutes. 28.4% of our patients had at least one complication. Majority of them were minor complications. Only 6 patients needed a readmission, and 3 patients surgical recovery. Majority of our complications were treated by surveillance or medical treatment. It's one of the largest series in the literature on the specific type of high-risk endometrial cancer treated by robo-assisted procedure. Our conversion rate was also 7.5%. In the other studies dealing only with high-risk endometrial cancer, the conversion rate was for FADER 9.9% and for COSCAS 5.3%. But in these 2 studies, they have included all type of mini-invasive surgery, and few cases was only robo-assisted procedure. The only study on robo-assisted procedure with high-risk endometrial cancer was the study of FIRE. With 17 patients, they don't describe any case of conversion. For the secondary endpoints, we had described 28.4% of post-operative complication, no perioperative complication. In the other studies, including high-risk endometrial cancer. Perioperative complication rate was 0%, was 17.6% for failure and 11.8% for postoperative complication. And for Salehi, who had described 48 patients treated by a robot only, they described 2.1% of perioperative complication and 22.1% of postoperative complication. It's like us, about like us. The our mean operative time was 288.5 minutes. In the other studies, this time was lower, but we have taken all the surgical procedures skin to skin, and we don't have exclude the docking time, so we explain like that our longer time. So with this data, robot management of high-risk endometrial cancer appears for us feasible and associated with low morbidity. Retrospective data on the small number of patients are limiting factor for our study. Further prospective study are required to confirm this data. Thank you for your attention.
Some question, please.
And Sophie, thank you. How do you explain the high rate of mortality? The mortality rate, which is very high.
Mortality rate? We don't have any case of. It's the mortality rate after recurrence of endometrial cancer. We have any case of mortality.